Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario. We have Dr. Ryan Bailey that works with us at Safe Pet Anesthesia. And I'm Dr. Gianluca Bini, CEO and co-founder of Safe Pet Anesthesia, a training and teleconsulting company. And I'm also an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right, so tonight we have Dr. Natalie McShane from Eastside Animal Hospital with us. She's our special guest for tonight. Natalie, it's a wonderful GP out in Charlotte, North Carolina. Thank you so much for being with us. It's kind of exciting
to be here.
It's kind of exciting to have you on because I met you probably first time about a year ago.
Yes, I was crying on the phone. Do you remember? Do you remember the first conversation we had?
I totally remember that first phone call. I was actually, I think at that time I was locuming at U of I, so I was really near Ryan. And I was in my Airbnb and I pick up the phone and there's Natalie over there that's desperate to find a solution for her practice. And I was like, well, we can totally help you. And I love how you went from that to the level that you guys have now of anesthesia is incredible, right? You're one of the best success stories I have. And how can you change the way a practice actually does anesthesia? And it's insane. And so I'm by the way, extremely proud of you and your team. But, I wanted to have you tonight because we see anesthesia in, tertiary referrals. We see anesthesia in very highly specialized centers, right? But sometimes we forget or we kind of detach from what actually happens.
Yeah, we detach emotionally on purpose because it's terrible.
Yeah, because we can't. Yeah.
So true.
Okay.
I don't want to know sometimes what's going on because it's, I'm sure, a terrifying state of affairs. But yeah,
Okay.
Literally, we don't even know.
Okay. Well,
there is no standard, right? What is really, that, we're kind of talking before the pod started.
yeah.
I did relief before I was.
Well, for everyone, just to recap the pre-recording conversation, which was Gianluca originally introduced Natalie to Ryan and I as being a GP who used to have nightmare-inducing anesthesia. And then because working with anesthesiologists has really brought the level up to far above average, so has been on this extremely positive trajectory, which is a great example. But we were actually chatting about, what's the bare minimum? What are the best practice standards? And, I think Natalie mentioned something like she's probably done relief or locum work in over 30 clinics and maybe one had a capnograph, which is why I drank pure vodka on the podcast. So anyway, so that was the pre-recording. So we have a GP here with us tonight to keep us humble.
No, but do you think that that's so? Okay, not having the capnograph is not a good standard of care, right? But do you
unless and who always wants to have a Doppler on a desert island,
I know GPs who a friend of mine actually, she doesn't have a capnograph. She has everything else, but she'll keep the Doppler on them the whole time, just playing, so she can hear the heart beating.
Yeah. See?
By the way, the monitor does the same thing if you turn off the volume.
Yeah, but the monitor makes a lot of beeps for a lot of reasons that are not associated with actual pulsations. We all know that.
Okay.
And I think this is where kind of you get into the different varieties of standards.
As long as the heart's beating, anesthesia's a win, right, guys?
At the bare minimum, Bartel. At the bare minimum.
You think? I'm not going to congratulate people for that, really.
I never said I was
really what you were taught. That's what she was taught. You know what I mean? It's so when I graduated, was during the time where like there were no jobs for vets, right? So the best you had was like the big box corporations that will be no named. And they literally give you like a chart of the protocols that you need to use, like, or should be using.
The chart I knew about, you had to mix two drugs that us anesthesiologists would have had a fucking aneurysm over. And I was like, what a stupid chart.
Like, they're not, to looking back now and what I know, like, I was only in that for a year and when I first got out. But looking back now, especially with what I know, is like, it was not the analgesia and the sedation would not be enough for these procedures, like, and the patients that we see.
Yeah. I think the part of this is our fault, right? Like, I think the fact that, people out there don't have, even today, right? Like, you're talking probably like what, 2012, 2008, something like that?
Yeah.
Is more, yeah.
Like 2014, yeah.
Yeah. So around those times. But like even today, right? The fact that people don't have capnographs around, or people don't have, a freaking syringe pump, right? Like,
Yeah.
people, I think that part of it is our fault, right? In vet schools, right? I'm not saying in terms of anesthesiologists. I think people that do teach in vet school, I think that we giving the students this false idea of there is different standards of care, where in reality there is only one fucking standard of care, and this is the minimum, and like anything above is great, but there shouldn't be anything below that, right? Like, if, thank God, now we have a 2025 ACVA guideline that says that capnograph is the minimum standard, one of the parameters that we need to monitor for anesthesia, right? But like till then, people were thinking that capnograph was this gold standard, and then there was a whole sorts of shades of standards underneath that, right? When in reality, there should be a standard of care, one standard of care.
100%. But yeah, there's some places that just still, like, I see it on the Facebook groups where they'll say, like, working in a clinic today, all they have is a pulse ox. And you're like, or even the assistants that come to work for us, like, we'll introduce them to, which that's the best part about using the service, is our techs have become so well trained, like in anesthesia and monitoring and adjusting the equipment. Not that they weren't, but I mean, above like what relief vet come, and they're like correcting the relief vet on like how the like capnograph works and how to fix it and all that stuff. So
That's amazing, right?
listen, this is what it's like in the trenches, okay? This is like, is it too much? Is that really? I really hope that's vodka.
I just can't wait to retire. I just can't wait to retire. Yeah. I don't know, Beanie. I mean, I certainly was not trained like that when I went to vet school, and I'm the oldest of all of you. And
You also went to vet school in Europe.
yes, which is the smarter continent.
And there may be a difference in the standards that are taught. I mean, there's a significant difference amongst the standards that are taught within different vet schools in America.
But I guess my question is why? Why is this happening? I don't understand, because honestly, 90% of it is not that complex. Like, I'm not asking you to do lithium dilution cardiac output monitoring. It's like, put an oscillometric cuff on and read a number. Like, seriously.
No, but I get it.
We do all that. I always have done all that.
It's
the only thing that we didn't have was, before we met him, was the capnograph. That was it. I mean, we do all that.
But maybe we're missing like the larger point. Like if you look at what is being done across the continuum of like veterinary medicine, it's so similar to what's happening in human medicine. And we're just like, yeah, there's one size fits all. You go to 4 years of vet school and you're fucking done, and you move on and you just get out in the world and you do whatever the fuck you want if you want. And like, that's totally fine. But like in humans, you've got to do 1 year mandatory, like basically in human medicine, as far as I'm to understand, you have to do 1 year mandatory, like internship. And then you can go on to whatever you're going to do next. You're not like kicked out the door and going into practice the following day. And then there's a continuum within human medicine of like, there's your general surgeons, there's your cardiothoracic surgeons, your blah, blah, blah. But like, we're starting to do that, but we haven't actually caught up yet. So we're like, so at academic institutions, you're doing really high level anesthesia all the time, because that's what people in those institutions want to do primarily, because they want to push the envelope, advance the medicine, advance the care that we're doing on a daily basis. And the only way to do that is to do it at these higher levels where they have access to all these tools and equipment. But then at the same time, it means we're losing that training time where we can actually teach how to do basic day one anesthesia practice on like everyday cases that are generally healthy and are all going to do well, and like teach the ins and outs of like how capnography works, how ventilation works, what do we do about CO2, why do we care about the heart rhythm, blah, 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 all that. So like, I mean, like, I don't have an answer, because like, I think
I had a great like anesthesia in vet school, and then great like rotation at NC State.
but how many
But
weeks?
like 2 weeks, right?
Right.
And then you're
Yeah. Did
it's
you see in
100%.
2 weeks?
And then you're studying for boards. You've got internal medicine for 4 weeks after that, right? You're like barely sleeping. And then you get into the real world, like in practice, right? Like I couldn't afford to do an internship. I had to like pay my loans back.
For sure. Yeah.
That too.
Yeah.
So it's like then you get into practice, right? So I started working for a big box corporation, and you're being mentored by that person, and you're given this like a book essentially of like this is, and then you kind of learn your mentor's protocols and you get used to that, and then I don't know, I feel like that's what I hear. I was taught this and that's what you're most comfortable with. And
Yeah.
so I feel like I've always been comfortable with monitoring and things like that, but I was never as comfortable as I am now with troubleshooting.
Yeah.
Like,
Do you think the
I find
failure?
it.
Sorry.
Go ahead, Beanie. Sorry.
I was saying, do you think that the gap, so the disconnect comes at the vet school point? Do you think happens like knowing what you know now, right? Like, so now you know how to troubleshoot things, you know how to work, do a very good level anesthesia, right? Do you think that the disconnect happened, at vet school? Do you think it happened between vet school and now? Like, was the issue,
vet school
practice?
and going into like general practice, because the degree of like standards of are so different. Like I make my techs scrub sterile multiple times, like all the things. You might go to a place that just does alcohol. Do you know what I mean?
Yeah,
Yeah.
yeah.
Place can IV
Do you think
catheter.
that issue is?
We do.
What?
Sadly, we know exactly what you mean. I mean, what you guys are all describing is what I have struggled with for 25 years, which is the failure of how veterinarians are actually trained, and what's choose to be prioritized. Like, you get we always say this, like your 10 business days of anesthesia, and then you go out into practice and realize that over 80% of your cases need to be either sedated or anesthetized, if not more, to manage everything that you do. Meanwhile, you've got vet students scrubbed in on TPLOs for 8 weeks, and half of them don't know how to sedate, right? And don't know how to intubate, and don't know how to leak check the machine, and like seriously 101 shit. And I think there's a big problem, there has been for a long time, in how we are graduating these students and what we consider to be day one competencies, and how we're actually then stepping you up from being a student to being an independent clinician. And I also think it speaks to how we've chosen to value anesthesia as a specialty, which is why I count my seconds to retirement, because, you get, it's totally undervalued. And, most of the time you're learning anesthesia from someone in practice who's not an anesthesiologist, who sucks as well, from these big box booklets, which are trash. And, like, I remember my first job out was also for an American big box vet school, a vet company. And, the anesthesia quote protocols were written by like 3 GPs on the other side of the country. That was their awesome standard. And I was like, okie dokie. So, I think it's multifactorial for sure. But I think the real underlying problem is that no one's really rethought how to evolve the training of veterinary medicine. And we still admit students based on the same criteria, which we know is in many cases failing formula. We have not changed the way that we choose to educate them. We don't, try to in any way, we do not seek out innovation. It's like we want to backwards melt as a bunch of big glaciers. And then, we get out into practice and it's just the wild west of clinical practice. And it's disappointing because of the work that you put in and the commitment that you have. And then, that's that standard that we're pretending exists just plummets. And at the end of the day, what suffer these patients, right?
Yeah. And not only is it like, here we doing the anesthesia, right? Like, but I'm also removing the 25 teeth. And so it's like, sometimes you love having the service because it's like, I can focus on what I'm doing and it's hard sometimes to do both. And I used to do both, but having a good tech who's really well trained, who knows it, because we do the CE, who knows exactly and then having someone, because it's like life and death. I mean, they're essentially like, you go to a human, you're human, like you're having a C-section, I had the OBGYN's not going, how does the blood pressure look? Like, you'd be like, you have an anesthetist and a CRNA, like, who's handling that while they're doing the bulk of the procedure,
I mean, like for me, anesthesia it's my full-time job. It's like in every case, I'm using my whole brain to think about the case. And like when like if someone was like, here's a scalpel, I'd be like, cool, I'm just going to slash my throat.
You use your whole brain, Bailey?
Yeah, I use my whole brain. I would not be using the scalpel. Like if someone hands me the scalpel, I don't know what the fuck to do with it. I'm just gonna be like, all right, I'm gonna go somewhere else. And like,
yeah, you would. Surgery's not that hard, honestly. Like cut so, monkeys can do it. Like, come on.
Yeah, I'm not gonna go there, but I think it is. These are all important skills and they all need to be recognized for the importance that they are. And I think, interestingly enough,
I'm not a surgeon. Don't blow smoke up my ass, okay?
Yeah, that's not where I come from, Bartel, all right? And, going back to last week's conversation, maybe there's a place, well, not last, for the viewers out there, it's probably like last month. So like, follow along.
Last episode.
The last episode. But like, I think there's something to be said about like the potential loss of skilled veterinary technicians in the field and like the diluting down of the veterinary technician education, because they are the ones doing the majority of the anesthesia. We, the doctors, are the ones making, like in GP, you're the ones making the plans for the most part. And then it's kind of like, you got your own stuff to do. And so the technician's the one usually doing a lot of the active management that I would be doing on a case myself. And now that we don't have as many skilled technicians in the field too, the education they're getting is like fucking way worse nowadays, because there's just been a proliferation of schools offering like lower and lower quality education and blah, blah, blah. It's a fucking mess, if you want my opinion. But I think that also hurts the whole specialty of anesthesia in general.
I think it's a real recipe for disaster. And I think that is reflected well if you look at the mortality comparisons between referral centers and GP. And it's just that you would never get away with this in human medicine, right? You would never get away with this in human medicine.
But they're one-to-one.
And and before everyone launches into the explanation, what's the difference between vet med and human medicine? I get it. I just don't care, right? Like, I'm just like, just be better veterinary medicine.
It's that, but you know what? It's like, besides anesthesia, I see it in medicine in general, in the things 100%. That I see.
You see it, honestly, I'm picking on anesthesia because obviously it's the coolest specialty. But it's true in everything. I mean, because when you work in like referral centers, academic, private, doesn't matter. There is a very significant portion of your caseload, which is basically what I call search and rescue, which is saving other people's fuck ups. And, you get these, cases that come days, weeks, months into things where essentially, and I'm going to be very transparent, they have been grossly mismanaged, right? And it's to the detriment of the pet, and it's a detriment to the client because you've used up a lot of their financial resource. And the problem that we see is, of course, we have to be very mindful, right? Like usually the veterinary oath says you can't really drop another veterinarian directly in the shit unless they've actually done something so incredibly negligent or incompetent. And just to be clear, in the last 6 weeks, I've reported 4 different veterinarians for incompetence because I've had it up to here with the bullshit. But anyway, you see this in referral practice, and it's across all the specialties, right? Like things I've seen in my life are TPLO plates being put on back to front, right? Like they've been put on inside out. I've seen non-intramedullary pins being placed through, like, for example, like into a humerus, and then it's fractured its way through the ulnus and the radia. So, things like the patients being treated for Addison's when it's not Addisonian. So it is wild in general, and not specific to anesthesia. And like I said, when you become a specialist, one of the things that really starts to leach the will to live from your soul is the fact that you see these cases where it actually is quite 101. And we don't hold these people accountable, and our recredentialing of everybody across the spectrum is incredibly lax. And again, it goes all the way back, and it begs the question about how are we training people in the first place, and why are we not emphasizing what we call day one competency, and why is there not a continuous, like when we were on the podcast with Gianluca's wife Kristen, who's both a human and a veterinary professional, and she was saying, like, you have to recredential continuously, and like you can't touch like the blue button until you've gone through like 2 years of continuous course learning. And I get that capacity doesn't exist for us, but we continue to.
Right, that's the problem, right? Like, why couldn't it exist for us, right?
That's
like, why there is nobody, right? Like, there, when you go to England, the RCVS sets the standard,
yeah,
right?
So, question: in Europe,
are
all of the veterinarians practicing like a similar standard of care? Would you say
higher standards of care?
higher
Yes.
standard?
100%, 100%, because
like,
they lose their fucking license.
Yeah,
that's how it is. But there is somebody that actually does check or whether you're doing shit or not, right? Like, here, it's the fucking Wild West. You open your practice, and then God the fuck knows what happens in it, right?
Well,
like, nobody comes to
sometimes
you.
people, I will say, like, there is this is how I feel, like there's almost like this when you're in GP, and I don't know if it's this feeling of like, oh, you can't do everything, you got to know how to do it, you don't know how to do that, oh, you're going to refer. And like I told Gianluca, like, I refer all the time. Like, if I have a hard derm case, I'm always like, hey, I just want to let you know, I'm happy to do what I can do for you and try it out and do all the things, like, when I know it's going to be complicated. But just so you know, there's a dermatologist. Or, like, I'm happy to do this for you. We could spend $700 like doing anesthesia to do x-rays and all the things, and you still might have to go to the specialist and get all that done. And it's like, even as a practice owner, it can put like a pressure on you, like, oh, like everything you refer out of the door, like, is like, you should be, you know what I mean? And like, I told Jen, look, like, I don't care about that anymore. Like, I'm going to do the gold standard, the good quality. And if it's a client who wants me to like pin the ulnus and radio, which I'm never doing, I'm not doing that, I've never done that, it's not something that I'll ever do, then like, that's not something that needs to come here. Like, they can go to the guy down the block, or the other side of town who does like orthopedic surgeries, who probably shouldn't be. You know what I mean? Like,
100%. I mean, there are still people out there who actually hide referral as an option, which technically is a violation of the ethical code, right? Like up here, you can definitely be reprimanded formally for not giving referral as an actual option. And there's still people who grossly overstate what their capability is. And I know that a large part of that is driven by, you want to keep the business in house because you got to keep your head above water. I also understand there's a certain faction where, you do the best that you can because you're the closest veterinarian for 5,000 kilometers. Like, it's like,
100%.
I could be the only person between like Moosonee, Ontario and Saskatchewan, right? And it's you or nothing, because those people are not flying their dogs to Toronto for care type thing. But there are people out there, like they go to one weekend course for, whatever procedure, and they market themselves, for example, like there are a number of people who market themselves, quote, as surgeons, and they are not board certified. They've only done additional like lateral suture courses, and they'll wear, like, they talk as if they're surgeons, and there's no accountability from the regulatory board. And one of these individuals geographically close to me, like I've personally had to anesthetize probably 5 patients where we ended up doing amputations on because it was terminal in terms of the ability to salvage the limb, right? And it is so hard to get another vet to report them, which is part of the problem. It is huge failure associated with the education of the client population about what the difference is between board certification and not. And it's just like I said, there is a proportion out there of people who are hiding referral as an option because I know they're trying to tag all that business within house. And I'm a chief medical officer, and I often get calls from referring veterinarians who are pissed because, for example, they took the chest rads for cardiology and then we repeated them. Or we took chest rads and then they were pissed that we didn't send the patient back for them to take chest rads. And it literally, like, there is a total disconnect between what the variability in terms of quality and necessity are, right? And these people are like irate, like, how dare you do this, like, blah, 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 like, refund the client. And I'm like, so what you're telling me is that you believe that your cardiac workup is equal to that of a board certified cardiologist. And they're like, yeah, I can do the leg when they're just there to interpret. And I'm like, no, right? Like, it's just a no.
I'm like, bye, go to the cardiologist.
Yeah. So, I mean, like I said, I think it's a huge problem culturally, and I do think there's a lot of variation between where you train and where you practice. Europe is significantly more stringent in certain capacities, but yeah, I in anesthesia in particular, we know that 95% of the anesthesia happens in GP practice, and we know that there's a chunk of that that's being done superbly, and we know that there's a chunk of that that's being done not so superbly, and most people probably fall a little bit in the middle. And it's that old adage, right? Like, certain X amount of pets are going to do well no matter what you do. A certain number of pets are going to do badly no matter what you do. And then a few percentage of them, like the 2 standard deviations from the mean, they fall into one of the other categories. But, yeah.
So like, maybe not, I have a different thought process here, maybe.
Okay.
And maybe I'm just going to take everything and go a totally different direction. But like, maybe the question I have is, what can we all do to like do better for our patients? Like, what can we do, the anesthesia teams, to like help? And like, what did, Natalie do to like do better for her patients? And I think the thing that I think about from both of our sides is we kind of leave our egos at the door. And like, Natalie,
That's not necessarily true. You can still have your ego.
No, you're right.
but like,
It's honestly the communication between the specialists and the GPs. We are really lucky that we have in this area. We have like a bunch of specialty hospitals, and there's one that we work with, and like I can reach out to if the client doesn't maybe want to go today, I can reach out to. It's like having that door, and also not feeling like judged by the specialist, because sometimes like
who's judgmental?
Oh, please.
really
You're like,
easy
what do
to,
you mean you don't even put a cuff on? You know what I mean? Like, we're doing the best that we can. Like, GPs out here, we are in the trenches. We have to know a little of everything,
For
know?
sure.
Yeah.
I don't have to know half the shit you know. I know a lot about one very specific thing, which is why I did what I did. Because like,
Bailey, you also know a lot about hot dogs. Don't undersell yourself.
Love a good hot
my
dog.
ego's way too high to not know everything about one specific thing. And so like knowing a little bit about everything made me really super anxious. And it's why I went into specialty, because like I wasn't comfortable being an ER vet. Like in my internship, it was like hellish for me. Like I
Oh, I
was
would hate
so
that.
uncomfortable not knowing everything. And like I just want to know everything about one thing and be able to pour all my energy into that. And that's why I chose to specialize. And why I felt like I had to do it. Probably didn't help. I went to a specialty that like, made my anxiety go to like, 100 out of 10, but that was my choice. But like, I think what I was saying about ego is like, I think we all, the collective group of us, all have to like take our egos down a little bit and recognize like we can do more for our patients, and we the specialists can do more for the larger population if we're willing to like accept and work with and try and find common ground with, the vets who are coming to us for help and who are saying like, hey, I want to find a way to like do better. Like, hey, I'm not going to be able to restructure the way veterinary education is done in America or standardizing is done in America, but I can at least help people who, want to come for help. And yeah, That's
I like your happy little hopeful vein. I just agree that we should tone our egos down. I think, if anything, anesthesia for a long time has had the issue of being tread all over, and we don't have enough people standing up for the specialty. Like people who are like, well, I'm going to ask surgery's permission, or, I'm not going to fight about, this blood work or whatever that I think is necessary. And I do not agree with that approach. And I also think I'm absolutely going to be judgmental. But I do agree that we do need, it boils down to two very simple facts, which is not different than anything else in life, which is education and communication. And from my point of view, I still do as much external CE as I can. And I really focus my CE to be on RVTs and GPs specifically. I have a very phone me anytime policy for no charges. So when I do speak, I make sure everyone gets my email and my number so that, if you do want to talk through a protocol ahead of time, or if you have something on the table that's not doing well, or you're just generally anxious, I give virtual seminars for in-clinic training, right? Like I try to promote stuff like John Luca's company, Safe Pet Anesthesia, where you can have a phone a friend on board, right? So I do think that individually, there's a lot we can do. And despite the fact that I'm both egomaniacal and judgmental, but for me, that's really a defense mechanism for the fact that my entire career anesthesia has been so undervalued. And
I couldn't imagine.
I do think that we need to put our dukes up a whole hell of a lot more and not just sort of be so passive about the way that the trends tend to move. But yes, I think that there's a ton it's so weird to me because, for example, Natalie, you were saying, you came from a really strong school, and I know the anesthesiologists there, and I have a huge amount of respect for how they actually do train and the kind of anesthesia that they practice, except for Gianluca, obviously. And anyway, but it's as soon as everyone leaves vet school, they forget that they can still call people for help. Right? It's always why didn't you call me before this happened? Right? Why didn't you, there's 21 anesthesiologists in the city of Toronto, pick up the phone. One of us will help you. But again, that's part of the communication and the education, right? So we're very much like the wizards behind the curtain. And, it's time to pull the drape back and really start to insert ourselves back into the conversation and back into the practice. And really, if we want to do best by the pets and we really want to support vets, particularly when we're looking at things like mental health, because anesthesia is a top 3 source of anxiety, we have to take onus for that. We do. Because Bailey said, I'm not going to change how we all go to vet school unless I directly get involved in that. And honestly, I will develop a full-time drinking problem. So, this is what I'm choosing to do. And Bailey, I know you do that kind of stuff. And Beanie, obviously you do that kind of stuff. And I guess, Natalie, my question for you is what more do you think we could do to reach the GP population and sort of bolster that sense of commonality and support? And how do we get more into the trenches with you guys so we can effect a better change?
I think it's exactly what you said, the CE, giving out your number, John Lucas service, all those things. But there are certain vets that are not going to ever ask for help. Do you know what I mean?
And we're never going to reach them, though.
Been this
You know what I
That's
mean?
the way it is.
But you know what? You don't focus your energy on the bottom 10%, right? You focus your energy on, you really put it in for the top 10%, and you get them as ground level cheerleaders for you, and they will help bring everything up with them.
Exactly.
Yeah.
You find
I try to spread the word.
Trust me, I have worked places where you find the people who are going to be your allies, you make them your allies, you use those allies to then change the people who are not your allies. And so that's what it is. It's focusing on, people like you, Natalie, who are going to spread the word and say hey, there's these services, there's these people, you can call them
because people don't know about that. I remember putting it in the owners group and just saying oh my God, I feel like a relief because I'm the only vet here, and it always feels nice to have another vet in the building with you. You don't realize what it's like when you don't have one. And so, and all of our cases are aggressive, need 37 extractions, have a grade 5 murmur.
She's 100%.
It's never here's Polly Pocket. She's 1 year old and she's getting a scaling. I've never done in this practice that I own, I've never done just a simple scaling. It's always
But see, I think going back to what you were saying, Dasha, I think that your vision of anesthesia and how it's undervalued, it's true in referrals. I never had a GP that reached out, and the reaction I always had was always, thank God you exist.
But that's a selection bias, Gianluca.
But I don't know. I mean, do you think
There's
because like
select population who's reaching out for help. They're going to be grateful because they're reaching out for help. It's a selection bias. Sorry.
It's
Not
true. I do think on the whole, no, I actually agree with Beanie, and I agree with both of you. You're both right. I do think that I don't think there's animosity towards anesthesiologists from the GP population.
No,
And
not at all.
in the VTS. It's not like when I have to have these like smackdown stairwell, who's going to cry first conversations with surgeons. I'm not picking a specialty whole, but and P.S. it's never me who cries. But anyway, it's not the GPs and the RVTs, and I always find that even when you present or you engage, or like there's word of mouth about like you come into the clinic and you do a case which is like a teaching case with them, and I've had a lot of people reach out to me saying like we really struggle with rebreathing, for example, during our cases, and so then I'll be like, well, let me come in and run a case with you and see what you're doing, and then we'll talk about what's going on, type thing. And so agree that they love it, right? Like they and my hospital and even like the provincial RVT conference that happens every year, the single most requested type of CE is anesthesia.
100%.
100%.
You guys
And
are also zebras. Like there were no anesthesia. There's one anesthesiologist here now in Charlotte, but I want to say before her recently, the closest would be state.
Yeah.
So like,
it's crazy.
and I went to St. George's. So like Stefano, I couldn't, like, he scared us all because he would like, do you remember I told you about him? What's his last name? I can't remember. Stefano's his first name.
Di Concetto?
Yeah. He was like, he was a great professor, but he was very like, he made it.
It's in LA now.
Yeah. I remember hearing stories. He used to go, obviously he was watching through surgery when we were doing student surgeries, and he would close the pop-off valve and see if somebody was watching to see if they would notice.
Borderline.
He was right there. He was right there. So he wasn't going to let anything happen, but he was wanting to see, like, are they watching the bag? Are they watching the pressure? Are they doing what they need to be doing?
We need a sound effect for cringing, because Bailey and I both cringed at the same time when Natalie said that. We were both like, oh, good. But I understand the principle. I'm just not sure about the execution. But yeah.
Let's try to kill this patient and see if you realize.
I mean, that's like 9 times out of 10, my hand is on the pop-off while running a case. I just stand there touching it just so I know what its status is. And it's like a thing I fiddle with from time to time as just like a nervous...
Is this the same thing you do with the vaporizer? With
the pretending?
The same motion?
That's just to fool whoever's talking about the case. But I also often... I'm also one of those people who languishes with my hand on the pop-off when I'm primary on the case too, because I've also left the pop-off closed accidentally. Yeah, everybody has. And you lie if you don't. It's like peeing in your wetsuit. You either pee in your wetsuit or you lie about it. So same thing with the pop-off valve. But yeah, I also, my hand's often on the pop-off valve, especially if it doesn't have a safety release on it too. So I get it.
See, I don't know. You guys make it as this, like, I could never be a specialist because it's already really difficult to be a veterinarian and feel like people value, like, you are a doctor and like you went to medical school and all these like physiology of all the things. I could not imagine putting the blood, sweat, and tears into being like a specialist. And then someone would be like, can you do the nail trim while he's under for his cardiac like bypass? I'd be like, I'm done. I can't. Like,
that totally happens, by the way.
Can you clean his ears while he's under for the double amputation? Like, I'm like,
thank God we don't deal with clients, because I would be like...
Yeah, we don't deal with clients, which is a great specialty.
Which is both a pro and a con, I will say, I always feel.
I actually deal with clients. I don't agree that anesthesia shouldn't interface. I think that's part of our problem of being valued. And I don't like other people talking about like anesthetic risk and what have you. So obviously I insert myself with a great degree of distrust to the other specialties all the time. But I mean, it's just wild to me that you go under these crazy cases with anesthetic risk and, and like some first year neurologist has explained it to you. And then no, I'm making that call for sure. So anyway, that's a whole other That's a whole other podcast. But
also to like tell the clients, to give the clients like, hey,
I mean,
this
Natalie,
is
to your point, I just want to clarify that becoming a specialist is a horror show. And I still have PTSD, which I've now chosen to just block out. And then anytime I meet people, like someone was talking to me today about somebody who's triple boarded. And in my head, I was like, FREAK, what a freak you must be. Like, I don't think that people who are double and triple boarded are necessarily mentally all with it. And so I just want to put that out there. But I'm like, yeah, no, I wouldn't specialize. I wouldn't vet again personally, and I wouldn't specialize again. I just literally took
is just
years off my
at
life.
the moment.
Years off my life. But
because like the other thing I was talking to an internist the other day, like about a case, and I'm like, God, I could not be you, because when it gets, they're always like, okay, when it gets to a place where I'm like, hey, this is a case that's like way over my head, I can like punt them to internal medicine. And if I'm the one they're punting to, I'd be like, oh God, you know what I mean? Sometimes you're just like, you're the specialist, you are like the person, you know?
well, see, that's the problem, right? Like people peg you as being like omniscient, and we're not, right? Like I don't know everything about anesthesia, and neither of these two, and Lord knows the three of us are just making it up together.
You know way more than I would know, right? Like you would have way more experience in doing like
Yeah, because we do it every day, all day, and so a lot of our acumen comes from experiential medicine, which technically is the lowest form of knowledge and science. So that's always uplifting. But yeah, I think that. Woo,
she's a ray of sunshine.
but yeah, no, I do think that people like, there's this weird expectation that we're supposed to know everything and have like full capability. And sometimes, specialists, it can be hard to say, I don't know.
Oh, 100%.
No, I haven't seen that paper. I didn't read that. And then the other thing that happens too, right? Like, you study for boards, and you would have had this for like NAVLE and all that kind of stuff. Like your head is stuffed with this and like 90% of it falls out. And if you don't use it all the time, and then, you're just like, oh, God, I used to know this, right? And like, it's somewhere deep in that recess, but it's not fresh enough that, for example, you could teach it. So, there's plenty of like subtopics in anesthesia where if someone invited me to lecture on it, and one of the things I choose to do is I choose to lecture because that helps me retain the information and keep it fresh and forces myself to keep myself updated, right? So like, if I talk about a certain thing, I'm like, I really got to go read about this because I was a resident 13 years ago. So yeah, specialists, it can be very uncomfortable to have the buck passed to you with the expectation of omniscience, omnipotence, and perfection. And let me tell you, if you think clients are bad, if you guys lose a patient, if you lose a patient as a specialist, if I've lost a patient under anesthesia, they will try to hang me from like a yardarm for it. Like there's zero forgiveness. And that's part of the anguish, right?
I could not. Thank you.
But I agree with you, but like also like I feel like what Ryan was saying, like I think it's I really commend GPs out there because they actually manage to have the huge knowledge of like different things. Like I have no fucking clue of vaccines my dogs need, right? I tell people all the time, like I take them to a fucking GP. Like I don't like I don't know. Like I have no clue what they need. Like I know that their appointment it's in 2 weeks, and I'll find out then what the fuck they need.
Did you ever do GP, Beanie?
What?
Did you ever do GP work, or did you just go straight into training?
No, oh, okay. Fuck no. I just went straight from vet school into rotating anesthesia internships and then anesthesia residency. Boom, that's it. Like never stepped a foot. Huh?
Did you do GP, Bailey?
Not as a primary, but in my internship, we did do GP.
Gotcha. Okay.
Yeah, we did. I mean, we were primary on the majority of ER cases we saw anyway, and we did have a GP arm, so we also kind of saw ER cases that were GP cases essentially, and like we had no ER doctors to oversee us, so we were kind of winging it because the only person you had to go to was a criticalist, and if you asked a criticalist what vaccine a dog needs, they probably would have killed you like in the middle and then, like sit on your dead body. Like it was an intense experience, and I don't blame them. I have a question for Natalie. What do you think? What do you like as someone like in the trenches? What do you wish we knew or could do to like help you as you're coming up? Like, coming through the shit, to like reach these pets that, we're unfortunately not reaching, and you're getting kind of a mishmash of like good quality education and then kind of mid-tier and then maybe some stuff that's like kind of dog shit because it comes from, like a piece of paper that you were handed by, some faceless person.
I think it's the CE and then also being able to talk to a specialist and not feel like an idiot.
Do you think that
That happens. Like, you guys don't understand that.
Oh yeah, for
And
sure.
I posted one time because I had talked to not a specialist in this area, and I asked them a question and I said, talk to a specialist today, and made me feel like an absolute idiot. Has anybody ever had that? And I'm not even kidding you. On the group, it was like 200 people were like, duh, every time. Like,
who does that? Like, so I'm a specialist, right? And I deal with probably 70% of our clients are GPs, right? And I hope we don't come off this way, right? Like, I hope we don't come off as like, I can't figure like how does a specialist make you feel like an idiot?
because I
Like,
think sometimes they're overworked and they have a lot of patients. And you might be like, well, so I never try to call a specialist unless I'm referring, because I think it's not, they're very busy. And so to be like, hey, can I ask you a question about this case? Unless I know them personally and I'm like, hey, girl, can I ask you a question about this case? But like, because you have to, if you're going to refer, but I think it's because they're busy and then they think like, they forget that that's all you do. Let's say like cardio. All you do is cardio all day long, right? I'm doing cardio, optho, derm, behavior, like vaccines, heartworm treatments. Like, I know a little bit of everything. And sometimes if it's something that maybe I don't see often or and they'll be like, "Ugh, you didn't know that?" That kind
like
of like,
behavior, like they actually act that way.
yes. And yes, ask any GP that will tell you that everybody in their career has had like multiple. Yeah.
Well,
Okay.
that's disappointing. I mean, I don't think you should be afraid to reach out to specialists because, quote, we're busy. I mean, everybody's busy, right? And I think there has to be that acknowledgement that that's where you really want to take some time is to support each other because it's already a big enough struggle, as we've all just described, regardless of what area you practice in. But yeah, I mean, I don't see what purpose it serves to be like, I know this sounds weird coming from me, but to be condescending about it, right? Like, I'm actually, very supportive, and I understand that because you guys are jacks of all trades, or because maybe you have like, the RVT's been out for 6 months and they're terrified, and or you came from a practice, where the ACA did the cohat and the anesthesia and the monitoring all at the same time, and so there's this broad spectrum of experience. But I don't see what purpose it serves to be like diminutive in that capacity because you
I
just
think
contribute.
95%
You
of the
contribute
time.
to the problem, right? You're contributing to the
Yeah.
problem.
It's 95. I would say it's a small, I would say I don't usually deal with it, but it's like definitely.
But that's sad, right? Like, in the end, like, if somebody's asking you, is because genuinely they, they need help, right? Like, what's the purpose of like being a fucking prick when, you
Or
either
to
don't
transfer a
answer it.
case, right? Like, hey, I'm transferring this case. Like, did you do the like da 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 da? And it's like, no, like,
Yeah, but I either ignore you, or if I answer you, I do it with some level of normal, like civil manner, right? Like, I don't, what's the point of like answering it and then being a prick about it? Just you either keep quiet and ignore it, right? Pretend it never happened, or you know what I mean? Like, you either don't pick up the phone or don't answer the text or pretend you didn't fucking read the email, right?
yeah,
Or if you do, then do it in a civil manner, right?
yeah.
Like, and
And sometimes like, there's a certain like referral. Most people that go to referral, like they know what they're getting into price wise, right? Like, you have someone who really wants to pursue that. Like, we're seeing people who might come in and say, like, I don't have like a lot of money, and like we're just trying to do whatever we can possibly do for them.
yeah,
Yeah.
It's just nice if everyone kind of works together for what I call contextual care, which is like the best for whatever circumstance that patient and that client are in specifically. I don't believe in quote gold standard type business, but it's in this moment with this patient, with this set of resources, with this set of knowledge, with this set of financial like capability. Like, what is the best thing that we can do to affect an outcome that is meaningful to the pet, right? If specialists aren't supporting GPs in that capacity, shame on you, whoever you are. Shame.
But where's
Like our
the
neurologist
specialist
here,
role
she's
in
the
that?
best.
Like, where's the
What'd you say?
specialist role in because who do you go to when you need a specialty consult? Like, ignoring anesthesia, like who would you like? How do you resource them?
There are local places.
Yeah, you
Like
go to
where
like whatever local specialty hospital is, you give them a call, and like they've probably done a CE because they're fishing for business from you, and they do a CE and they build a relationship with you, and like what they're doing is trying to get you to refer cases to them essentially. But like, where's the broader college's support of that? Like, where's the ACVA and then even the Navis group of like, where is their, hey, here's your local anesthesiologist, give them a call anytime. They're like somewhat local to you, they have resources, education, they can, I don't know.
I mean, I think a lot of people don't want to be bothered too, right? Like, I get it. Like, if you're
We don't
busy,
know how to do it.
like,
I'll call, anyone can call me and like, hey, Bailey, I got this case. It's doing super craptastic under anesthesia. I like enjoy that stuff kind of. It's like, all right, let me think and
because
use
you
my
guys are
brain.
like I'm telling you, you're like zebras. Like
Oh, I know. But we're not. There's a bunch of us who are around. We're not always doing something. We can field a phone call. Like, even in my old job, I would routinely get calls from our DVMs. Hey, this dog won't get sedated. What can I do? What can I give it? It's angry, and I've given all the drugs I know. And I'm like, all right, well, just let's double up what you've already done, and it'll be okay. And oh my God, it works so
I
great. Thanks
used
so
to be
much.
and we're also taught to be like afraid of Domitor.
Oh my God. So
Don't call
in
me. Don't
exactly
call
10
me.
days, I'm giving a talk called Stop Being Afraid of Dexmedetomidine. That's the
Don't
actual
call
title
me.
of my talk. I'm giving a full-blown CE called Stop Being Afraid of Dexmedetomidine because it's pissing me off,
I'll
right?
teach
Like,
you how to not be afraid of acepromazine.
I had a friend do her dental here, and I'm like, I think she's gonna need some Domitor, and she's like, no, I think I'll be fine. She did, I think, midazolam and something like a hydro.
when you just
And
shoot water.
the dog woke up like not terribly dysphoric, but like dysphoric because like we had a little Domitor on the board, she'd have been like, yeah. But we're taught to be afraid of it. And then the dosing varieties, right? The bottle, I've never gone off the bottle. I've always gone off the 0.0025 mgs per kg.
0.0.
You'd be like given tons based on the,
Hell yeah.
yeah, yeah,
Hell yeah.
yeah, yeah.
Hell yeah.
Ryan is not the right person of this conversation.
I'll give you a nuanced
Company
approach to
Davis.
it. I'm not just going to be handing it out like it's fucking candy, because it's not.
None of the drugs are candy.
Exactly. Thank you.
None
No, but it's a lot worse, right? Like to give too little, right? To give Madaz and Torb to a dog maybe that has tracheal collapse and is going to turn blue because it's so
Maybe skip
scared
the
you're trying to get
midazolam.
its IV catheter in. You know what I mean?
That's how you kill it.
Literally.
That's how you kill it, literally. Question for you. So I want to ask you a couple of questions that are a little bit different than what we talked about there. So, you've been, I want to see what do you think is the client perception
Oh,
of
yeah.
anesthesia,
Mm.
right? So when we, for example, right now you've been using us for a year or so, like you probably have been offering it to your clients, right? Like, so how
They
do
don't
they,
have an option.
okay, perfect. So you don't even give them the option, which is great. But like, do
Yeah.
you go over what we do? Like, why there is this charge that suddenly appears on your estimate? Like, what's their take? Like, what do they say?
They love it. So they love that anesthesia scares pet owners like 100, just like it scares. I'm scared to put my own pet under sometimes, just like it scares us to go under. And I think when we explain, like, hey, these are anesthesiologists, just like you have an anesthesiologist. And because, like I said, our procedures are never simple. People are always like, oh. And so we give them the website, they read about it, it's on our website. And so that's why it's included in our fee. And so our charges would be on the higher end, but you're getting quality service. So, for example, we had one time we did with you a 16-year-old cat who we were doing a dental on with extractions. Blessings, bless you. And
Yes.
he got hypotensive while he was under. We were still doing his extractions. And before I worked with SafePet, I would have done everything I know, turn him down, turn up his fluids, all the stuff. And he wasn't responding to any of that. And so John Luke was like, all right, let's get the dobutamine going. And I was like, okay. And what do you know? He did great. We were able to finish the procedure, wake him up. Cat's doing amazing, right? It's been like 8 months since that. But in GP before that, I would have been like, okay, he's got to go to the dentist because I can't get his, and he would have had to have another procedure and all that stuff. So explaining that to people, and they're like, they're so appreciative. They just don't know because nobody explains it to them.
Yeah. So you think it's, in general, like I think it's because there is a lack of offering out there, people don't know that this is something that, it's an option out there, right? Like,
yeah. And it's just the whole standard of care. Like it's the whole, they don't know. Like that's the thing for the clients is like, they don't know. And so they come for the skin issue. They want the steroid injection because they don't know, like, yeah, that's the quick fix that you might have gotten at the previous, but that's not like the good thing for them,
I've started, we probably like for probably 6 months ago now, we updated our website, right? Like before we didn't have a way to, they could call us or send us an email, but nobody, there was no form or contact us or anything like that. And we've been getting probably at least once, I want to say once a week or every 2 weeks, we get random requests from clients and pet owners that they're like, what's the nearest hospital or nearest vet they use you, right? They're like, I'm so worried about anesthesia and I want to know, in my area, who's using this service or, can I bring it to my, my GP or whatnot? But like,
we've had clients just come from finding you on our website.
Yeah. I mean, that's crazy. Like, I think actually clients are interested in something like this. It's just probably they never had the option. Like that's the thing that kind of like, it's interesting to see. I mean, at first I thought, when we started this, I was like, okay, nobody's ever going to use this. I was like, nobody's ever going to want this service. Nobody actually cares about anesthesia out there. Looking back at that, I was like, okay, I was totally fucking wrong. Like, actually, people want it. It's just that they never had the chance.
I don't think anybody thought it was like something that was like affordable, right? Like, so when I posted it to the owners group and everybody was like, tell me more about this.
Which, by the way, she wasn't sponsored for.
It was not sponsored. They were like, are you sponsoring this? I'm like, no, I'm just like so grateful. It's just like taking a weight off my shoulders being by myself and having to do 45 teeth out. But, and everybody's like, I didn't even know that was a thing. And how much is that? And that's not bad at all. That's doable. And then other people hired you and put the same thing. It's like, we don't know. Nobody knows it's out there. People care. I'd say majority of vets care. They just don't know what the like best option is.
The possibility. Yeah. I think that's.
This is part of my soapbox. We, the anesthesia community, need to market ourselves better. Our target audience unfortunately, isn't you, Natalie, in all honesty. It's the pet owner. Like, that's who I've always thought our market is.
Like, as an anesthesia, like college, you mean?
Yeah,
right?
It's informing that we fucking exist just in the world and we're available in places. And how do you access us? There's just like...
We had a woman book who lived 2 hours away from here online because she thought we were an anesthesia person for her pet to have a parathyroid thing removed. We were like, whoa. So listen, funny story.
we don't do
that here. Like, but yeah. We should do a segment on the pod where I ask clients what I have so many good clients. I can ask them, tell me what you know about veterinary anesthesia, and I can give you the clips.
That would be amazing on your Insta. That would be amazing. You should totally do that. 100%. 100%.
We need to get a pet owner as a guest, like someone who's like somewhere out there on social media, not just like a random like,
I have a dentist who's like an influencer, like a small influencer. She'd be great. She has the best accent.
But does she have like a
I
pet?
re-
Does she
I
have like
mean,
a dog related or like a cat related?
Oh, she's
Cat
got like
related is
3
so
cats and a
sweet.
dog. Yeah, she's like a huge pet. Her pets come here. She's like huge, like loves. She wants to come watch me do a dental one day.
Oh
Interesting.
wow, that's scary. An actual dentist that want to watch you do, like an actual human dentist. That's scary as fuck. But yeah, I mean, so you say that you now have Norepi. You know how to troubleshoot things. I mean, that's amazing, right? Like, that's really 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 cool. Um, what's your favorite hot dog? We didn't have.
Chili cheese dog, like Sonic the Hedgehog.
You're from the South, I assume?
I'm from New York.
Really? And you're a chili cheese dog person? Interesting. I've recently I read a book about hot dogs and I found that like chili cheese dogs are really common across like the American South. Yeah,
look at this.
that's their thing. That's their thing apparently. Like Chicago has a Chicago dog, New York has like the dirty water and like the sauerkraut and the onions, which is interesting that you didn't choose that. And then the South apparently just has a big swath of like chili dogs like all through it.
Does everyone in America like to crap their pants on the regular? Like, what's wrong with you people?
I mean,
Like
The
chili
food
cheese
quality.
dogs and sauerkraut and onions. Like, oh my God, the amount of adult diaper sales must rocket in the States.
my wife said before meeting me, she didn't understand how much meat some people ate, and she says that it's a very common Midwestern diet to like eat a multiple meat dish situation. So I feel like the chili cheese dog is in that kind of wheelhouse.
That's
Amazing.
awesome.
Yeah.
Reminds me of that SNL skit where they used to pretend to be like the Bears fans with like Ditka, and then like they periodically somebody at the table would have a heart attack, and then they would just like
Yeah.
pre-cordial them, and they would come
Yes.
back, and then they go back to eating their hot dogs again. Like,
Uh,
I have a question for you. What do you guys think of GPs?
what do you mean? I like. I think they're under resourced. I think they're under resourced and undertrained. And like I think we the veterinary colleges and specialists
Oh, she cut off. She's like, can't even make a
can't
comment.
even. I think they're just at such a disadvantage and it's a bummer.
Yeah.
And like we don't do enough to help them is my honest opinion. Like and I
100%.
think it perpetuates there's like all these problems that end up becoming perpetuated and like you said the like not wanting to refer cases because you want to keep that business in house and then like there's it's just such a
Yeah,
it's
I
just
think
it
the
sucks.
lack of help that they have, and like the fact that we're asking them to do so many jobs at the same time, that's the I really commend them. Like I'm glad that somebody's doing it so I don't have to do it, but like I don't think we're putting them in a fair position,
No,
right?
undertrained and they're just at such a disadvantage because like the specialty colleges don't do a good job when they're students and then they go out and they it just is a random crapshoot of what they're going to get as far as like mentorship and then things get perpetuated because it's just hard to do it's just hard like yeah like I don't know. There's a cynical part of me that's like specialty hospitals only go to GPs because they want your business and they do lectures for you as like as a thing, which is really just a phishing attempt for them to try and get you to refer cases, and that's a really cynical opinion, but also probably not that far from the truth.
that's why.
They
But
don't want the pod to make it.
no, right? I think it's incredibly difficult to have to know all these different things, right? Like, I mean, if I like, just keeping on top of, which medications do fleas and ticks but not mites, and which ones do heartworm and fleas and mites but not ticks, and it's just like that just makes me want to burst into tears. And on top of that, you've got it's a totally different age as well because now you battle the entire content of the internet. And it's just, I think it's incredibly challenging. And I think veterinarians in the face of social media and the internet have lost a lot of respect. Like they're not esteemed the way they used to be. Like, it's almost like people enter that relationship already in a cynical way. Like they think that you're trying to rip them off, or you think that you're trying to sell a product because you're in line with Hill's Nutrition, or I don't know. It's not a very James Harriet vibe anymore. And it's detrimental to the people who are practicing. And so, like I said, I mean, I do the most that I can to try and support them in my particular capacity. Because I remember what it was like to be a GP, and like you're trying to, do surgery while there's a kitten trying to die from hookworm anemia at the same time that you're training 4 technicians at the same time that someone's mad because, their dog popped 2 stitches because they let it run around for 3 hours outside type thing. And it's just honestly, it's too much. And, yeah, I don't know. I unsung heroes for sure, except for that 5% that I like to report for being incompetent.
I think we all serve a big, we all are part of a little, like all of us serve our own little special role in the big picture of veterinary medicine.
Yeah.
That's why, I don't like to shit on surgeons like Bartel does, because, we all,
I think Bartel is unique.
We all work together, hand in glove, as it were.
Gonads big enough to say it. Give me a break.
What's the beef with the surgeons?
Have you met a surgeon?
Yes, let me tell you, we have the nicest ones here. One of them came and helped me with one of my surgeries once. I called her crying in the middle of it, and she came and helped me.
I'm happy for you.
That hurt Bartel so much I could feel it through the computer.
No, it's just I like to tease the surgeons specifically. Yeah, I have met some very nice surgeons. Yep.
Do you love a good hemilaminectomy?
No. BORING. But no, it's I don't think, I think a lot of anesthesiologists will agree, and you guys can jump in and correct me if I'm wrong, but the people who are least supportive of anesthesia as a specialty are the other specialists. And I am just exhausted after all these years of railing what I feel like to be in the minority and against, it's constantly an uphill battle about being valued and respected. And I just don't want to do it anymore.
So you don't feel respected by the other specialties?
Oh, I'm respected. But, I think as a whole, it's a struggle, for example, in terms of equanimity across pay. And it's a struggle to, it's just 1,000 little microaggressions that are disparaging towards us.
Yeah. Yeah. No, that I feel I think you're right. A lot of places or specialties, they don't feel like we are as important. And some of them, they blatantly don't care, right? But I think more than, I think things are changing. I think things are, people are more and more seeing the importance. Probably in the past, that was true. I feel like the newer diplomats, 99% of them do actually see the value. But, probably some older school people were like that.
I mean, everybody has a 10-cent opinion on how to do anesthesia until the shit really hits the fan. And then all of a sudden, that's all on you, right? But, they've heckled you down to your toes up until that point because they want this, they want that. And I'm like, oh, shut the fuck up, right? It's just shut the fuck up. So anyway, it's just not been a pleasurable career experience for me. And I'm sure that's part of the issue. And I have met surgeons that I like and respect. Shout out to them. They know who they are and they are loved. But on the whole, it is part of the anesthesiologist shtick to just keep the surgeon's ego in check.
On that note, guys, we're coming up to the hour. I will thank you so much, guys. I'll see you in the next episode. All right.